When you really look at the landscape of medical diagnostics, you usually expect a certain level of, like, engineering precision.
Oh, absolutely. Like a broken bone.
Right. You fracture your tibia, the radiologist points to a jagged white line on the x-ray, and the path forward is just objective. It's binary,
Mm.
broken or not broken.
Yeah, and that visibility is really comforting for patients.
It is. But when you step into the world of neurology, uh, that desire for a clean mechanical diagnosis gets heavily challenged. I mean, you find yourself navigating this diagnostic landscape that is incredibly complex and, well, heavily reliant on pattern recognition.
Oh, completely. It's a whole different ballgame.
And nestled right in the center of all that complexity is this conflation of terms. It's so ubiquitous that even seasoned clinicians, they occasionally trip over it. We're talking about the tendency to use the words seizure and epilepsy interchangeably.
Yeah, treating them as synonyms when biologically they represent entirely different physiological realities.
Exactly.
It's honestly one of the most consequential diagnostic blurs in modern medicine because collapsing those two terms, it obscures the fundamental mechanics of what is actually happening in the nervous system.
Right, because words matter.
They really do. Treating an event as identical to a chronic condition, I mean, it derails the diagnostic process before it even begins.
Okay, let's unpack this. Our mission for you today is to completely untangle these concepts. We're going to look under the hood of the brain to understand the exact neuronal mechanics of these moments, how the diagnostic frameworks are actually constructed, and we'll break down the International League Against Epilepsy's modern classification system.
Which is a brilliant framework once you get the hang of it.
It really is. And by the time we finish this deep dive, you'll be armed with this highly effective 3-question mental checklist. It's a tool that just cuts straight through the dense neurological jargon.
Yeah, giving you the ability to systematically understand and classify virtually any seizure you might encounter, whether it's in clinical literature or just in real life.
Exactly. So where do we start?
Well, having that specific diagnostic scaffolding is vital because any intervention, like any treatment plan, relies entirely on the precision of our language. So we have to start by pulling seizure and epilepsy apart.
Let's do it.
A seizure is, strictly speaking, a paroxysmal event.
Just a single event.
Right. It is a discrete moment in time characterized by an abnormal hypersynchronous discharge of a population of cortical neurons in the brain.
So if we think about the brain's default state, we're essentially looking at this massive orchestra playing a highly complex, beautifully synchronized symphony, right?
I love that analogy, yeah.
Like different sections are playing different notes, perfectly timed, constantly balancing excitatory and inhibitory signals. So a seizure then is like the entire brass section, suddenly ignoring the conductor and deciding to just blare a single continuous note at maximum volume.
That is exactly what happens. It's a sudden failure of the brain's inhibitory networks to keep the electrical firing in check.
Right.
And that local hypersynchrony forces nearby neuronal populations to either try to drown it out or they just join in.
And that sudden electrical hijacking results in the actual clinical manifestations we observe.
Precisely. Depending on which specific, section of the orchestra is misfiring, the patient might experience motor symptoms, sensory hallucinations, maybe behavioral arrest, or even profound autonomic shifts.
Wow.
But the critical takeaway for you here is that the seizure is just the storm. It's the event.
And epilepsy.
Epilepsy, conversely, is the chronic underlying condition that lowers the threshold for those storms to occur. It is the actual diagnosis of an enduring predisposition to generate those events.
Which brings up a really interesting friction point in the diagnostic criteria. Because looking at the standard definitions, a clinical diagnosis of epilepsy traditionally requires the occurrence of at least 2 unprovoked seizures, occurring more than 24 hours apart.
Right, the classic 2-event rule.
But that rule feels almost agonizing from a patient perspective. I mean, if someone experiences one severe unprovoked seizure, it seems completely counterintuitive and frankly terrifying to leave them in diagnostic limbo, just waiting for a second event to prove they have a chronic condition. Do they really just sit there and wait?
That's such a good point. And, that waiting game used to be a massive blind spot in neurology. But the modern framework has actually evolved to close that gap.
Oh, it has.
Yeah. The 2 unprovoked seizure rule is still the classic pathway, sure, but clinical judgment now dictates a second, equally valid pathway. A patient can be diagnosed with epilepsy after a single unprovoked seizure if, and this is the key, if their probability of recurrence is exceptionally high.
How high are we talking?
Specifically, if their recurrence risk is estimated to be over 60% over the next 10 years, which happens to be the baseline risk someone carries after already having 2 seizures.
Oh, I see. But clinicians aren't just making a subjective guess about that recurrence risk, right? Like, they are looking for hard evidence.
Absolutely. They're looking for electrographic or structural evidence that the brain's internal seizure threshold is permanently lowered.
Like an MRI.
Exactly. If an MRI reveals, say, a focal cortical dysplasia or maybe an old ischemic stroke core, they have the physical smoking gun right there.
Or an EEG, I'd imagine.
Yes, or if an EEG captures clear epileptiform discharges. So things like interictal spikes or sharp waves, even while the patient is sitting there perfectly conscious, it proves the network is inherently unstable.
The wiring is already sparking, essentially.
You're right, meaning the clinician doesn't need to wait for a second clinical event to validate the diagnosis and start anti-epileptic therapy.
Which fundamentally changes the timeline of intervention.
Exactly. The presence of that underlying structural or electrographic abnormality is what definitively moves the needle from just an isolated event to a chronic disease state.
You know, the operative word there, and really throughout the entire epilepsy diagnostic criteria, seems to be unprovoked.
It's a very important distinction, yeah.
Because the requirement that these events be unprovoked points us toward a massive subset of seizures that actually are provoked, right? Events triggered by an acute, transient insult to the brain. And the pediatric statistics on this are just staggering.
They really are.
Like, roughly 5% of all children will experience at least one seizure in their first 5 years of life. 5%.
Whoa, that's a huge number.
In a standard kindergarten classroom, statistically, one child has had a seizure. That's wild.
It is wild. And what's fascinating here is that despite that incredibly high prevalence, the overwhelming majority of those children will never develop epilepsy.
Really? Never.
Never. Their overall neurological baseline is perfectly healthy.
Right.
What we are observing in that 5% is just the fragility of a developing nervous system when it's subjected to an acute stressor.
Right. A stressor that temporarily plummets their seizure threshold.
Exactly. The classic example being the febrile seizure.
Oh, from a high fever.
Right. It's not necessarily that the child's brain is structurally abnormal, It's that the myelination process is still incomplete and their thermoregulatory centers in the hypothalamus are immature.
So when they get sick.
When a viral infection causes a massive sudden spike in circulating cytokines, driving the core body temperature up rapidly, it's that sheer rate of temperature change that provokes an electrical surge.
Wow. So the event is a direct mechanical consequence of an acute systemic trigger.
Precisely. The seizure is completely provoked by the febrile illness. And, we also see this in adults with severe metabolic derangement.
Like what?
Like acute hyponatremia, where a sudden drop in blood sodium disrupts the osmotic balance across neuronal cell membranes, and that leads to rapid depolarization. Or in cases of acute toxic exposures.
Okay, so the trigger is outside the baseline brain function.
Right, and once you resolve that underlying trigger, like you cool the child down or you correct the sodium levels, the seizure threshold returns to normal and the likelihood of spontaneous recurrence drops to near zero.
Which is the ultimate illustration of why a provoked event, no matter how dramatic the physical symptoms are, does not equal epilepsy.
Exactly. It's a totally different beast.
So establishing whether an event is a chronic pattern or just a provoked anomaly is step one. But when we look at the International League Against Epilepsy's modern classification framework, it's clear we need a highly standardized way to categorize the events themselves, right?
Yes, the ILAE framework, it's essential.
And it relies heavily on semiology, which is the objective observable clinical signs unfolding during the event, and it maps those signs to the underlying neuroanatomy. The very first axis of this framework forces us to identify the location of the onset, dividing the geography of the brain into focal onset, generalized onset, or unknown onset.
And that anatomical distinction is everything because it dictates the entire clinical approach.
Let's break those down. What's a focal onset?
So a focal onset seizure originates within networks limited to just one hemisphere. It might be a highly localized neuronal circuit in the motor strip or a broader network spanning a whole temporal lobe, but it is fundamentally asymmetrical at its inception.
Okay, isolated to one side.
Right. And these were historically classified as partial seizures. That's a term you'll still encounter frequently in older literature, though focal is the precise modern terminology.
Got it. And when dealing with focal seizures, the immediate next step in the ILA framework is determining the status of the patient's awareness, right? Which replaces the older simple versus complex partial designations.
Yes, we've moved away from simple and complex. Now we just look at whether consciousness is preserved or impaired.
But biologically, I mean, what dictates that loss of awareness? If the abnormal firing is locked to just one hemisphere, how does it manage to knock out consciousness entirely?
Well, it really comes down to network involvement. So if the focal hypersynchrony remains isolated to, say, the primary motor cortex of the left hemisphere, the patient might experience involuntary rhythmic jerking of their right arm, but they remain perfectly awake and aware.
Okay.
Their consciousness is completely intact. We call that a focal aware seizure.
Makes sense.
But if that focal discharge propagates deeper into the brain and engages the bilateral thalamocortical structures or the reticular activating system.
Which are the deep brain networks responsible for maintaining arousal, right?
Exactly. If it hits those, the patient's awareness becomes impaired. They might stare blankly, maybe engage in repetitive automatisms like lip smacking, and they'll usually have complete amnesia for the event.
Oh, wow.
That is what we call a focal impaired awareness seizure.
Which contrasts sharply with a generalized onset seizure. Because generalized doesn't just mean a bigger focal seizure, does it?
Not at all. Mechanistically, generalized onset implies that the paroxysmal activity originates at some point within and rapidly engages bilaterally distributed networks right from the very first millisecond.
So it's essentially a massive thalamocortical loop firing in unison, activating both hemispheres simultaneously.
Yes, which is why consciousness is almost universally impaired at the onset of a generalized seizure. There is no focal warning, no localized aura. The entirety of the cortical surface is just being recruited concurrently.
That sounds terrifying.
Yeah.
And then, of course, the framework leaves room for reality with the unknown onset category, right?
Yeah, it's a necessary pragmatic concession.
Because if a patient is found alone, post-ictal on the floor, and we have no witness to the onset and maybe non-diagnostic EG data, we simply classify it as unknown onset, rather than forcing it into a focal or generalized box based on incomplete evidence.
Exactly. We have to be honest about what we know and what we don't know.
Okay, here's where it gets really interesting. Once we've established the onset location, the geography, we have to map that to the physical presentation. The ILA-E framework splits this into motor and non-motor manifestations.
Right.
And if we look at the specific motor patterns, it's fascinating how diametrically opposed they can be, all based on which specific neurotransmitter pathways are dominating the event.
Oh, the visual phenotypes of motor seizures are just striking. So you have tonic seizures, which involve a massive, sustained excitatory output to the descending motor pathways.
What does that look like?
Well, the skeletal muscles undergo this continuous, unrelenting tetanic contraction. The limbs stiffen, the back arches, the respiratory muscles literally lock up. It is pure, sustained rigidity.
Just totally locked up.
Yeah.
And that prolonged excitatory phase is often the precursor to the classic conic-clonic presentation, right?
Yes, exactly.
Because the brain doesn't just stay locked in rigidity. The inhibitory networks desperately try to fire back to suppress the seizure.
Yeah, it's a battle.
Right, so that alternating battle between the excitatory glutamate pathways driving the contraction and the inhibitory GABA pathways trying to pause it, that creates the clonic phase, the rhythmic, symmetrical jerking movements.
Exactly. It's the physiological push and pull playing out in real time. But then, on the complete opposite end of the motor spectrum, you have atonic seizures.
Atonic, so no tone.
Right. Instead of massive excitation, the abnormal discharge drives a sudden, profound augmentation of inhibitory tone. The patient experiences a complete instantaneous loss of postural muscle control. They literally drop to the floor.
Man, those must be highly dangerous due to the trauma risk from sudden falls.
Very dangerous. And we also see myoclonic seizures, which are these incredibly brief, shock-like cortical discharges causing a sudden muscle jerk.
Like a twitch.
Like a severe twitch, yeah. And then there are spasms, which have a very unique, slower kinematic profile than myoclonus, usually a sudden flexion or extension of the truncal muscles. We most notably see this in devastating pediatric encephalopathies like West syndrome.
Okay, but motor manifestations are only half the story, right? The non-motor presentations are where the diagnostic water gets really deep, because you can have a raging electrical storm in the brain with absolutely zero abnormal movement.
This is where it gets incredibly subtle. If the epileptogenic zone is situated within the sensory cortices, the clinical semiology will be entirely subjective.
Only the patient feels it.
Right. A focal sensory seizure in the occipital lobe might produce complex visual hallucinations. If it's in the olfactory cortex, the patient might experience phantosmia.
Phantosmia.
Yeah, suddenly smelling burning rubber or sulfur when there's nothing there. We also see autonomic seizures originating from the insular cortex or hypothalamus, and those drive inexplicable spikes in heart rate, profound flushing, or really intense gastrointestinal distress.
Wow. And perhaps the most distinct non-motor presentation is the absent seizure, typically generalized in onset. Biologically, this is fascinating. Instead of a chaotic electrical storm, an absent seizure is characterized by a highly organized, rhythmic 3 Hz spike and wave discharge on the EEG.
Yes, it's extremely organized.
The thalamus and the cortex get locked in this abnormal oscillatory loop that essentially hijacks the brain's default mode network. And the patient, very often a child, simply stops.
They just arrest all activity.
Right. They stare blankly for maybe 10 to 15 seconds, and then the loop breaks. They resume their sentence exactly where they left off, completely unaware that a temporal gap just occurred.
It's incredible to witness. And, if we connect this to the bigger picture, you can see why the ILA abandoned the old, confusing terminology for a more descriptive, mechanistic approach.
It makes so much more sense.
Which brings us back to that mental checklist we promised. To classify any event accurately, you simply run it through 3 sequential filters. 1, what is the onset? Focal, generalized, or unknown. 2, is awareness preserved or impaired? And 3, is the dominant manifestation motor or non-motor, and what is its specific clinical pattern?
So you end up with a label like focal impaired awareness, motor tonic-clonic, or generalized non-motor absence. It creates a universal language. But we have to address a major clinical trap here.
Oh, secondary generalization.
Yes. So what does this all mean for a clinician or a bystander who witnesses a massive full-body convulsion? Because a seizure that ends as a generalized tonic-clonic event didn't necessarily start that way, did it?
No, it didn't. Secondary generalization, or what the ILA now formally calls a focal to bilateral tonic-clonic seizure, is one of the most critical concepts in epileptology.
How does it work?
Well, an electrical storm might start in a highly localized focal network. Initially, the brain's inhibitory surround the localized GABAergic networks, tries to wall off the discharging neurons, basically keeping the seizure confined to that one hemisphere.
But if the paroxysmal firing is intense enough, it breaches that inhibitory wall, right? The discharge exploits the brain's major white matter highways, primarily crossing the corpus callosum, and rapidly recruits the contralateral hemisphere.
Exactly. It cascades into the thalamus and just blasts outward globally.
So to someone who walks into the room 30 seconds after it started, it looks identical to a primary generalized seizure. Both arms, both legs, loss of consciousness.
Yes. And the clinical implications of missing that distinction are immense.
Why is that?
Because a primary generalized epilepsy is often genetic, right? It's a subtle instability across all networks. But a focal seizure that underwent secondary generalization means there is a specific, localized anatomical lesion.
Like a scarred hippocampus or a vascular malformation or maybe even a low-grade glial tumor.
Exactly, something that served as the ignition point. And the entire treatment paradigm, including the potential for curative epilepsy surgery, hinges entirely on identifying that focal origin.
Which highlights why the diagnostic process relies so heavily on meticulous history-taking. I mean, the physician acts almost like a forensic investigator, asking the patient or the witnesses, did anything happen in the 5 seconds before the fall?
Those 5 seconds are gold.
Right. Did the patient experience a rising sensation in their stomach? Did their head forcefully deviate to the right? Did they start picking at their clothes? Uncovering that fleeting focal aura before it was completely masked by the bilateral spread is the key to unlocking the true neuroanatomy of the patient's disease.
Yes. And, the aura itself is the focal seizure. That's a crucial paradigm shift for many people to realize.
The aura isn't a warning.
No, the strange smell or the localized twitch isn't a warning that a seizure is coming. It is the seizure, just localized in its early stages before propagation.
Wow. Okay, let's pull all of this together. We've established that a seizure is the paroxysmal electrical event. while epilepsy is the enduring chronic network instability that allows those events to happen. And
Exactly.
the diagnosis requires a proven tendency for recurrence, either two unprovoked clinical events or one unprovoked event coupled with high-risk structural or electrographic biomarkers.
Spot on.
And we understand that a massive cohort of pediatric seizures are provoked events driven by acute thresholds, drops from rapid temperature changes, or metabolic shifts, not chronic disease.
Building on that, the ILA framework gives us the architecture to categorize these events logically. Based on onset geography, awareness status, and motor versus non-motor semiology, while always maintaining a high index of suspicion for focal events that rapidly evolve into bilateral network disruptions.
Right, so by internalizing this framework, you've basically installed a sophisticated theoretical scaffold in your mind. You aren't just memorizing terms, you're looking at the underlying neurobiology. You have the diagnostic vocabulary to look at a complex neurological event, trace the symptoms back to their anatomical origin, and understand the precise mechanics of the brain's electrical grid without being intimidated by the clinical jargon.
This raises an important question, though, and it's a concept that really stretches our understanding of neurological boundaries.
Oh, what's that?
Well, we discussed how focal, non-motor seizures can be purely sensory or autonomic, right? But they can also be exclusively cognitive or emotional.
Wait, meaning the hypersynchronous discharge is localized entirely within the limbic system, or the amygdala, affecting nothing but internal subjective experience.
Exactly. A patient might experience a sudden, overwhelming wave of profound dread, or a bizarre, hyper-realistic sensation of déjà vu, or even a transient state of depersonalization where they feel totally detached from their own body.
That's terrifying.
It lasts for 60 seconds, the electrical discharge terminates, and the feeling just vanishes. It forces us to wonder how many individuals out there might be experiencing brief, isolated emotional or cognitive focal seizures, but are completely misattributing them.
Oh my God, they write it off as a random mood swing or an atypical panic attack or a fleeting psychological glitch, completely unaware that they're actually experiencing a paroxysmal electrical misfire locked within a highly specialized network of their brain.
Exactly. They have no idea.
That reframes the entire human experience. I mean, it forces us to recognize that our emotions, our memories, our very sense of reality are all downstream products of electrical synchrony. And when that synchrony fails, the resulting storm doesn't always look like a convulsion. Sometimes it just looks like a sudden shift in the mind.
It's incredible to think about.
It really is. Thank you for taking this deep dive with us today. Take this framework, keep questioning the underlying mechanics of the world around you, and we'll see you next time.